Good day, colleagues, ladies and gentlemen. Let me start our today's event, organized by the Embassy, British Embassy, Moscow, Astra Zeneca Company, GE Healthcare, and Russian Society of Cardiology, jointly with the National Research Center named after Andrei Almazov. By way of introduction, I'd like to give the floor to Counselor and Director of Department on International Trade of British Embassy in Russia, Mr. Travel Hughes. The floor is yours.
Well, thank you very much indeed, Dimitri. And yeah, like you, I'd like to thank our partners today, Astra Zeneca, GE Healthcare, and the Russian Society of Cardiology. We have four highly qualified British speakers today representing Imperial College, Royal Brompton Hospital, Royal Free London, University Hospital of Wales and Cardiff University, and EMRAD, the East Midlands Network, as well as two equally highly qualified Russians, Almazov National Medical Research Center. And it's great to see and hear Russian and British experts willing to share their expertise, best practices, facilitate knowledge transfer, and ultimately contribute to the implementation of advanced digital health technologies in clinical practice. Cardiovascular diseases, so strokes and chronic heart disease, remain one of the leading causes of death all around the world. I think 19 million people sadly died in 2019 according to WHO data, and its prevention and treatment is a government priority both in Russia and in the UK. Indeed, it's a personal priority as well, as someone who had 3 stents inserted 8 years ago. So I keep a close eye on developments because I have a very personal interest in making sure the newer technologies are there to help us. And the use of digital healthcare technologies add value to traditional methods of treatment, and e-technologies, especially during COVID times, including distant patient monitoring technologies and telemedicine, remain very useful. And I think that's particularly the case in such a vast country as Russia. For those not so familiar with Russia, there are 9 time zones. So you can see that in some of the more remote parts of Russia, it's very, very important that they can have access to expertise which they can't get in person and need to be taught and learn online, and in some cases, obviously, assist with some procedures themselves. Artificial intelligence and digital technologies are the future of healthcare. And though they definitely cannot substitute a human mind or indeed human hands, they will serve as an aid to diagnose and treat patients, as I say, and that's particularly going to be the case in remote areas in countries as large as Russia. So those really were my brief introductory remarks. I think it's important that we hand over to the experts so that you can all learn from each other. But could I also encourage all the participants to take the opportunity to ask questions at the end of the presentations and get first-hand information from our experts today. They all have a lot to offer, and I think there's a lot to be gained. So I hope you have a great afternoon and learn a lot together. Thanks very much indeed. Back over to you, Dimitri.
Thank you, Mr. Lewis, for this introductory remark. Unfortunately, Mr. Academician Yevgeny Shlekhto is on a business trip, so hopefully he'll join us a bit later for an introductory remark or indeed for his presentation. So at this point, I suggest that we go on with our presentations. Without any further ado, I'd like to give the floor to Professor Martin Cowie.
Thank you very much indeed.
Representative of, sorry, the introduction still goes on.
Okay.
Representing Imperial College London. Okay, the floor is now yours. Thank you.
Dobry dzień, здравствуйте. It's a great pleasure to start this seminar talking about digital health and the rather twisting and turning roadmap that there might be to help healthcare professionals use these tools to improve the outcome for our patients and also the experience of care. My name is Martin Cowie. I'm Professor of Cardiology at Imperial, and I chair the Digital Health Committee of the European Society of Cardiology. But it's also a great pleasure as an advisor to AstraZeneca to be part of this seminar. I did Russian at school for 5 or 6 years back in 1980, but I'm afraid that's 30 years ago. So my Russian is not very good, and that's why I'm speaking in English. But anyway, let me tell you a little bit about the European Society of Cardiology. I'm sure you're all pretty familiar with this. The Russian Society of Cardiology and the British Cardiac Society are members of this organization. But I think it's helpful to remind ourselves that each country is different. There's enormous variation in wealth that's available, and also the health literacy and digital literacy varies between countries and also even within countries. Old Europe. On that, it's 57 national cardiac societies, and within that, 29 subspecialty communities or tribes, if you like, and often they have very different needs, very different use of technology and familiarity with this. But as you can see on the slide, we say our diversity is our strength. So it's the fact that we're working together to try and find solutions to navigate our way through to a more digital future. So cardiovascular disease obviously is the most important issue for this society, and it works in terms of education for our members, but also in advocacy and research. And our website has 400,000 visitors each month and is a real depository of information, but also opinion leading editorials and commentaries on the change that's going around us in the world, what new innovation is available, and how technology might fit into this framework. Bearing in mind that healthcare is highly regulated, usually quite conservative, and wants evidence before it changes the way it does things. But certainly the ESC is there to support its members. So if there is a change in practice, a change in evidence, a change in the way of doing things, we see ourselves as being there to support people with their education, with their networking. So it's great to have this meeting where people living in Russia, people living in the United Kingdom can talk about the challenges that we're facing and perhaps think of solutions that we can jointly push forward. The main event of the ESC, of course, is its Congress, where 35,000 people come together once a year to swap ideas, to learn about new developments. Now, with COVID, that has been very challenging and it's gone virtual, which has some benefits, of course, increasing access across the world to this, but also dropping the element of networking. So hopefully we will return to a hybrid option in the near future where we can combine face-to-face meeting with also a digital and remote offering. Education is really key, and I'll come back to this in the roadmap. It's about the fact that digital technology requires knowledge about how best to use it, and also people need to be supported to use these technologies appropriately and to maximize the value. Just because it's new doesn't necessarily make it better. So it's a question of learning and co-designing many of these digital technologies to improve outcome and experience of care. I trained in cardiology and I've been a professor for 20 years. Cardiology is very different now from what it was 20 years ago. Digital wasn't a term that was used very much 20 years ago. And now, of course, our whole lives, every aspect of our life is very much more digital. So things do change and we need to support people learning about cardiology. The other thing that's really important is to have data as to what's happening. In the absence of data, it's just opinion. So the ESC works very hard to collect healthcare data, not just outcomes, but also activity, and compares across those 56 countries. And it's very useful to think about the different ways that healthcare can be delivered, the ways that they should be delivered, and even within countries, why there might be differences and how we can use new tools to try and increase the access of our citizens to best therapy. Cardiology, of course, is not the only medical profession. So one of the roles of the ESC is to advocate for heart health. And in many countries, I think politicians feel that heart problems have been solved and it's all about cancer and dementia. So it's very important to remind people the fact that half of our citizens will die of cardiovascular disease. 1 in 5 of us will develop heart failure, for example. So this advocacy within the political arena is very important, both nationally and internationally. So let's go on to the roadmap for digital. And I don't think I need to work hard to persuade this audience that digital is part of the new normal. It's in every aspect of healthcare delivery. So on the right-hand side of this slide, obviously as professionals, we communicate with each other by email and various different systems. We collect data in our electronic medical records. We prescribe electronically increasingly, and we communicate with each other in different organizations in a digital way. But also patients do this. They're members of different social media groups. They communicate with themselves, and they also increasingly communicate with their healthcare team using email, and they may send files, PDF files, Excel files, etc. to us. And how does one deal with those data? Are they valid? How do we import them to our electronic medical record? How do we make decisions based on that? And what's the consequences? And then within our organizations, of course, I've mentioned electronic health records, but it's much more than that in terms of managing workflow and billing and other issues. So digital is in every aspect of healthcare now, and people need to know how to use these tools and also help co-design other tools to help us deliver healthcare need. The European Society of Cardiology published its first position statement on this back in 2016, when we realized that as cardiologists, we needed to be more engaged in the discussion about what's right and what's wrong, what the digital future should look like, from regulatory, reimbursement, but also even the simple thing about how much evidence do you require before you go through all the organizational challenges of changing the data flows, changing the way that you deal with information. And digital health, of course, is many different technologies put together. So telemedicine and telecare is very much more familiar to cardiologists with the COVID pandemic. Overnight, many of us had to switch from face-to-face contact to largely remote contact. mHealth with smartphone applications and also P-Health with wearables is increasingly something that consumers and citizens will be doing, often at a younger age group, but that's changing, and then expecting the healthcare system to deal with the information that may be acquired using those technologies. And that's a challenge on many different fronts. Decision support, image interpretation, artificial intelligence, machine learning, all of this is part of this digital approach. And I'm not going to talk about big data and the value that that might bring in terms of establishing the value of new interventions, and also perhaps where we make mistakes in terms of implementation. But these are the kind of domains of digital health, and the European Society of Cardiology put out a flag in the ground saying, we as cardiologists don't want to just be consumers of this. We want to be engaged with this from every aspect, from the design and co-design with patients and technology companies, the discussion with regulators, and also with reimbursement, which is necessary to support widespread implementation. So obviously, remote consultation is now very much ubiquitous across the world, particularly during the pandemic. And in many countries, actually, it is surprisingly easy to do this and very much more convenient for patients if they live far away from a center of excellence. There are challenges, of course, and it is difficult to examine a patient remotely. And sometimes it does require face-to-face contact to develop rapport and also to help support people with difficult decisions. But most cardiologists now across the world will use some form of remote consultation. I'm not going to touch very much on remote monitoring, although I've done research in that area for 20 years for heart failure, but a huge range of technologies that are available and require a lot of thought about how one optimizes these data streams, how you do not lose yourself in a tsunami of data, how we have support to make better decisions, not just more decisions, and how can we improve outcome and experience. platforms of care. But I think this is what the future looks like, and increasingly is there already with the Internet of Things connecting all of these different data streams. Some of them are very traditional and data collected in a healthcare setting that we're all very familiar with. But increasingly the data might be collected by the individual, by the patient, by the consumer, with an increasing range of technologies, many of which are actually very good at collecting the information. We will have increasing machine learning to support interpretation and management of these data streams. And even imaging can be done robotically. AI can support the acquisition of best quality images and then interpret them. So an individual could have the imaging done very close to where they live, and those images sent anywhere in the world for interpretation and advice. I've also put the picture of a drone there, where increasingly companies are getting into delivery of just-in-time, either medicine or a defibrillator or whatnot. So the future looks very different, has to be connected. And of course, we as cardiologists have to work to see what works, what doesn't work, what evidence do we require, and then how can we support high-quality implementation. Ultimately, I think patients, consumers, just our citizens will end up with really relatively straightforward getting a fingerprint of their health status at any point in time. And that can include, as you know, symptom levels, ECG, weight, sleep quality, oxygen saturation, blood pressure, all sorts of different things can be collected. The question, of course, is, do we need to know all of this all of the time? Or can we create systems that actually support individuals to look after their health, make better decisions, better outcome, and the healthcare system only to get involved where it makes sense? And that, I think, is where it's quite difficult. So the roadmap at the ESC is that we've set up a specific committee to drive this forward. So we have experts across many different sub-areas of cardiology, but also people that are expert in information science and the engineering aspects of digital health. We're seeking very hard to educate members about digital technology and some of the opportunities and challenges of that, and supporting them as it's implemented within their organizations. We are working hard actually to advocate at the European level for better engagement with technology companies, increasing standardization of the approaches and the evidence requirements for changes in practice. And we want to co-design right from the get-go with patients, with technology companies, with regulators. We want to be engaged in that, not just responding once the technology is approved for use. We want to be engaged much earlier on in that process. There are many barriers and solutions. I'm sure we'll talk about many of them this afternoon. It's easy to focus on the barriers, but we have to overcome these. And these are about literacy in digital and health, but also the legal frameworks. Reimbursement is hugely important. If the system doesn't reward the use of new technologies, it's unlikely to be adopted. The legal aspects often are of concern to healthcare professionals, worrying that if they make a decision based on data collected, let's say by a mobile app, and patient comes to harm, what is their position on that? On the other hand, if they ignore data that's collected remotely, that can lead to problems as well. And this is where we need to be engaged in the discussion right across society on this. And that was set up 2 years ago or so. And the last year with the COVID pandemic has accelerated all of these changes, and also the acceptance by healthcare professionals that digital is here to stay. In fact, 2020 has been called Tech Acceleration Year, where maybe 5 years happened in just a few months. So things have really moved forward a lot. Enormous investment globally in these technologies, and also interest in our citizens, albeit the younger end of our citizens, but increasingly even the older members of our societies have smartphones and increasingly use them as smartphones as opposed to just an expensive telephone. AI and machine learning is everywhere. Everybody talks about it. It's overhyped, but it does have a very important role in managing data, interpreting data, and making it easier for humans to deal with a huge amount of information. And the way we learn, of course, has changed, just as this seminar is an example of how virtual events can increase the reach of different educational topics. Just a quick snapshot before I finish. These are some examples of what we've actually done in practice. So we created a specific digital health event. Our first meeting was in Tallinn in Estonia in 2019. And you can see from the pictures there, it was like a tech conference, but we had stakeholders from many different aspects of digital technology there, not just healthcare professionals. We had patients there, we had tech companies, we had regulators, we had reimbursement people as well, discussing together what the future might look like and those challenges. This year, we couldn't have a face-to-face meeting, but we had a digital health week where we had panel discussions and interviews on some of the hot topics, which included devices and mobile applications, AI and big data, and telemonitoring and remote consultation, very much showing that this is the new normal and that we have to get to better use of these supports for a healthcare delivery. We've also launched a new journal, the European Heart Journal Digital Health, and it's already very successful with huge number of consensus papers, original research, opinion pieces, and please do consider submitting work to this. I put the web address there, European Heart Journal Digital Health, and many different topics across the whole of cardiology are talked about in that journal. I mentioned advocacy, and I think that's very important for us as healthcare professionals to get involved in the politics of healthcare and have a voice at least at the table, rather than just always responding to what people tell us we should do. And just very finally, we've taken a survey of our members about their familiarity and comfort with digital health. If you look at the top right-hand side there, you can see that most of our members would only describe their knowledge about digital health as fair. And actually, many people have very little knowledge of digital tools in healthcare. So we need to improve that situation, make them more familiar with that. And on the bottom right-hand side, these are responses. So nearly every cardiologist uses an electronic medical records system. Very familiar with that. They may not like it, maybe slow and clunky, not very well designed, but they use it. Increasingly, we use telemedicine and telecare much more, and that's COVID that's accelerated that. But when you come down to mobile health and personalized health, they're very unfamiliar with those technologies and how they should react to it. So there's a lot of work to do in moving together towards that more digital future. So great pleasure to be part of this conversation this afternoon, and thank you very much for your attention.
Спасибо большое, профессор Ковы, за прекрасную презентацию.
Thank you, Professor Cowie. That was a wonderful presentation.
Я с большим удовольствием
And now
представляю
I'd
слово
like to give the floor to our
генеральному директору Национального медицинского исследовательского
speaker,
центра имени Владимира Андреевича Алмазова,
the CEO
академику Российской академии наук,
of the
президенту
Russian
Российского
Society of
кардиологического
Cardiology,
общества
Director of Almazov
Евгению Владимировичу Шляхту.
National Medical Research Center, academician Evgeny Shlekhto. Dear friends, ladies and gentlemen, for me it is indeed a big pleasure and privilege to be present at our today's webinar devoted to such an important challenge that is related not just to the present but also to the future. Digitization and ways to make it happen that everything that we create and that we make is readily available to all the citizens. Indeed, the topic of digital technologies is very interesting, and I'll try and show you a couple of slides that I prepared for our today's event. Can you see my screen? Yes, we can see a screen. Obviously, if we look at the trends of our medicine today, as mentioned by Professor Covey, it's a trend for digitization. It's all about how to see to it that the patients are safe in their hospitals, the treatment is safe, and the positive outcome is achieved faster. Yet another part is related to value-based medicine. We can see that issues of value-based medicine are indeed very much interconnected with using information technologies in our routine operations. We're seeing the trends towards patients staying less at hospital. It's the trend hospital to home. Also, ambulatory treatment that is becoming more prominent, and it's going to be very much related to introduction of information technologies. A lot has been mentioned concerning COVID-19 pandemic and its role, and Professor Covey mentioned that. And I'd like to highlight that the pandemic has demonstrated that the information technologies have been developing quite fast. And of late, we're seeing that now that COVID is coming hopefully to an end, formally the patient goes from hospital to home, but they obviously need rehabilitation, right? And obviously, the rehabilitation events and caring, ambulatory caring, is related very much indeed, intertwined with information technologies. In the future, we aspire to see ecosystems, the ecosystems that are going to be directed at integrating all academic health systems, all hospital health systems out there, integration between professional and human resources and material resources so as to topple the geographic span barrier and improve and increase the availability of healthcare so that AI and ML and other IT aspects will be introduced broadly, not just for the sake of deployment, but rather as a way to achieve availability of service and increase the safety of medical care. So the matter of how fast we develop innovatively the things that do change the lives of our patients, this is what is of most importance today. We see artificial intelligence not around the corner, but rather inside our day-to-day practice, and we have multiple information on artificial intelligence being capable of making better decisions and interpreting images better. This has to do with CT, MRIs, X-rays, everything related to visualization. We see AI ubiquitous. Pathology, tissue and cells, dermatology, ophthalmology. These are the areas where artificial intelligence may well be more efficient and effective in analyzing images. This is something that allows us to have a broader use of artificial intelligence. We are currently a lot about privacy of data, safety of data sharing, and how to make it serve us rather than us serve something else. So we can see artificial intelligence developing all kinds of approaches, all kinds of algorithms, mostly related to data exchange, so that these data are not raw, so that they are more readily available for automatic processing. We can also see a lot of protocols for oncology. A lot has been made in ophthalmology, in dermatology, in oncology. So hopefully similar approaches will develop for cardiology as well. And we already see artificial intelligence and data processing for ultrasound images, computer tomography in cardiology developing quite well. And it allows us to free up creativity and time of our experts for more interesting things, more important things. We're in the data-driven medicine paradigm that makes use of data and develops with the help of data. And here it's all about confidentiality, right? It's all about legislative regulation And the regulatory aspect is something that we'll definitely have to cope with. And there are various approaches out there to do that. The so-called federated learning cloud that could create new opportunities. Everything related to confidentiality and data privacy is important. I suppose this is going to develop further, and indeed, this is in the zone of interest of all the researchers. Artificial intelligence is going to increase value of healthcare. The extent to which the precision tools are going to be used by doctors, the extent to which patients are going to be engaged into healthcare, which is another important aspect of effectiveness and efficiency to be resolved through digital technologies, the extent to which researchers get access to big data and get new data based on this resource, the extent to which hospitals and practices will be in control of this data. All this is the slew of questions that are of interest not just for the Russian Federation, not just for European Society, Cardiology Society, but far, far beyond. It's now far beyond European Society of Cardiology or Russian Cardiology Society. I'm more than happy that we are having this webinar today. I wish all of us best of luck, and this will become a very important next steps on the way of developing digital healthcare, and hopefully will be engaged in resolving our strategic tasks. Thank you for your attention. Thank you, Mr. Schlachter. And we keep going. And I'd like to now give the floor to Mr. Amit Bahai, consultant cardiologist, Royal Free London Trust, working for Royal Free London NHS Trust. So, Amit, the floor is yours. Amit?
Thank you so much. Can you hear me okay?
Yes. Yes, we can hear you.
I'll just shout a little bit more, and I'll just share my screen. Excuse me. And it's a great pleasure to follow Evgeny and Martin. Those were exceptional talks that they've just given, and I hope to do justice to the similar sorts of concepts that I'm going to be sharing when I can find my slides. Hang on 10 seconds. Sorry, guys. Just one sec. Okay. So Evgeny, in about 8 minutes, you've completely covered my entire talk, which is fantastic. So actually, I don't need slides whatsoever, which is even better. But let me tell you what I've been thinking. Here it is. Okay, so we've gone from Russia, we've gone from Europe, we're going down to London, and there are 3 points to cover in my slide. So I'm both a frontline cardiologist looking particularly after heart function patients. I don't like calling it heart failure because your heart has not failed until you've passed away. I have some declarations, and the summary of my talk actually builds very nicely on the 3 things that we've talked about already. So first of all, as doctors now, we are no longer fixing just patients. We will need to fix pathways, we will need to fix systems, and we'll need to make sure that the foundations are built in a way that they do not have any holes in them when we keep moving upwards beyond the black boxes that will be the foundations of how we think. Secondly, collaboration is the key. Data science, researchers, medicine, but actually everyone, patients, children, everyone will be able to innovate whatever they wish to do and however they wish to contribute, either through their data or through their thinking, their design thinking. And finally, after decades of reactive medicine, the age of prediction and prevention has arrived, enabled by data science and big data everywhere, but also our ability to challenge and communicate. This conference is an example, the ability to digitally reach anyone. We know that in the past, patients and clinicians interacted with knowledge to create interventions to improve patient care. And I'm literally just going to build up this diagram. Admit you don't need to read all of the text, It will always be the blue line is traditional, the red line is the innovation. And so we used to treat the organ, the body, the disease, and the illness for the patients. But now we also start treating the expectations of the patients. When will they go home? The quality of life, how will I be? And how will my family function both with me and without me while I'm in hospital? And then when I return, if I am disabled or am I fully normalized, how will my family interact with me? Clinicians used to be working on their experience through patient care, their training and their awareness and their ability to be educated to read and see insights. And that's the art of medicine previously. Now our clinicians, our youngsters are being taught to surf at the same time, simulation models, particularly during COVID, and they're connected to each other and they're connected to their patients and to the net at all times. Different type of clinicians. Building on what the patient requirements are, you're not just helping the patient, you're also helping the environment, the society, the insurance companies. So you're even looking at their driving status, their ability to take travel from air to fly, to actually travel abroad. COVID has taught us that these things are all impacted. In terms of the patients, we also have to think about their quality of life. And these are just some measures of different quality of lives that we use routinely now when we think about the patient leaving the hospital and making sure in 3 to 6 months' time that those quality life measures, their patient's functionality, their behavior, their expectations, their cognitive status of their mind, their confidence level is improving. As an example of fixing pathways, we've looked at the 5 years of data in the UK, getting 43,000 new atrial fibrillations. And we've found that every single year for 5 years between 2011 and 2016, 1 in 5 patients was not offered an anticoagulant or an antiplatelet for new onset atrial fibrillation with high risk for stroke. This is the sort of data access we have in the UK. We can actually search several million patients' records over 10 years and actually find 43,000 new AF patients. And when we find these 1 in 5 patients that have been given nothing, you can see that their mortality is 9 times higher, their stroke risk is over 4 times higher, and their bleeding risk is only twice as high. And so we can see that we are underserving these 1 in 5 patients. And if you treat them really well with novel oral anticoagulants, then of course they do so much better. If we look at the knowledge base that clinicians need to use, in the past, we've used data, publications, conferences like this, the internet, PubMed, Google Scholar. In the future, we'll have access to entire social data sets and machine learning predictors and patterns, as Evgeny has just said. But building on those, here's an example of a machine learning model from the same CPRD data set. Here are new patients. Now, these patients will get AF in the next 5 years. How can we find these patients before they get their atrial fibrillation? We can look at their demographics, and if we actually apply machine learning in top of the clinical factors that we already know from observational data sets like Charge UK, we can actually improve things by their amount of weight that is gained, the number of times they have their blood pressures looked at, different factors in terms of whether they have heart failure or coronary artery disease, and we can actually see that their likelihood of gaining atrial fibrillation in the next 5 years, we can actually reach a 0.827% predictability. So we can tell you with almost 4 out of 5 certainty whether you're going to develop atrial fibrillation in the next 5 years. This allows us to focus our resources when they're having their vaccines. We can do pulse checks. So now we move to the blue tests, the knowledge that we apply to patients, the bedside, the bloods, the imaging tests, invasive. And you've seen some of the machine learning technologies for looking at MRI scans of the heart. For amyloid, we can use NT-proBNPs, we can use live core cardia machines to detect when people may get atrial fibrillation in the future, so predictive technologies. But the new ones are we can actually predict scores for the patients when they come into the hospital, their likelihood of death before discharge, their likelihood of length of stay, their readmission rates. So there's a number of things, but more importantly, we can predict if the patient is going to take their medications and listen to our advice or not. This is a really fundamental aspect that big data and clinicians are finally starting to understand. What are patients' behaviors that we can help change with psychology and counseling to help optimize their care and their outcomes, because they're thinking about much more than just the organ that they've damaged. We can also in the future, when we do routine blood tests, send those blood tests to look for variants in COVID-19, viruses, variants in their genetic code. So we have the largest UK biobank in the world, which is 1 million people. And we've just extended that not only to have CT scans, MRI scans, but also their genetic structure and their disease profiling. And then we have a census, which we've just spent £1 billion on, that we're just completed in March the 21st for all 68 million residents of the UK. And so we will know whether these people are looking after others, whether they're working, what their occupations are. We can actually put those data sets together in terms of their postcodes and their needs. Here is the Cardio Live Call. And in COVID-19, we gave these to patients to be able to look at their QTC intervals temporarily while they were on antiretroviral medications and all sorts of other things. So a lot of data has come through, and this is now remotely utilized to anticoagulate patients for AF. Here's a technology that I'm really keen that gets forward, that when you're looking at a Zoom picture, the Zoom camera itself will actually try and notice what your heart rate is and try and detect if you've got atrial fibrillation. So even in this conference here, we should be able to find the 1% of people with AF that are not yet detected, and that would be really exciting. Looking at the interventions in the past, we inform patients of lifestyles, drugs and prescriptions, devices, stents, pacemakers. We gave them education, but in the future, we'll need to give them prediction scores, diet and supplementary advice. We'll have to think about monoclonal antibody technologies, such as the PCSK9 inhibitors, the RNA technologies, such as inclisiran, the vaccines, the digital prescriptions. We'll need to give them apps and different devices and wearables, and we'll have to allow them to have access to avatars that Sensily has created for heart failure, or chatbots or virtual monitors like Dockerbo. And then we'll need to give them peer support, let the technology connect them with other people similar to them to give them confidence. In terms of clinicians, we don't just focus on the patients at the time. We'll have to start focusing on the digital pathway, as I've said, and we'll need to focus on the entire system. In my hospital, Google DeepMind has created the first Streams app to be able to look for patients who between yesterday and today have a 20% rise in their renal function, and they're automatically detected to have an acute kidney injury. And this is the first technology of its kind in the world to automatically detect. We've also created the first ever Cerner UK pathway for detecting heart failure from NT-proBNP triggered by the blood test automatically, which has tripled our awareness of heart failure in our hospital. And to reduce the variances, Martin said there were variances between countries. There are many variances between hospitals in the UK, and we're using a group called Get It Right First Time to reduce those variances. So we're fixing entire systems, but it's not just about patient recovery. We have to not only do rehabilitation of the patient, but sometimes when we can only offer them comfort near their death, we have to be very good at end-of-life care. In the UK, here's some data that showed NT-proBNP pathways during COVID-19. This is raw data, and you can see the NT-proBNP is available in 1,219 patients in the middle of the screen there, out of the 3,077 patients that came in during COVID-19, just 4 months during our hospital stay. And we can see that behind age and C-reactive protein, immediately NT-proBNP becomes a marker of COVID-related death because a right ventricle under strain from acute respiratory distress syndrome was actually a real predictor in critical care, in ITU, who was going to make it, who was not going to make it. So those are just an example of how cardiologists keep innovating to look at things. Now, lastly, here's the UK setting where we've looked in 2018 at 12,000 deaths that occurred in the country, and we selected almost 1,000 of those deaths to find out what makes a good death, a bad death. We actually spend time in the UK analysing these deaths to find out that actually a good death is available in about 15% of cases, but many other cases there's so much to learn in terms of variances. We have so much rich data. In the UK, we not only have the national data sets, such as the NCPOD and NICOR and Minep databases, but we also have patients routinely giving us their data, reporting their outcome measures, and also rating clinicians. That will become something common in the future. How did you interact with this particular clinician? And then, of course, we will have the data from mobiles, wearables, and sensors. Those are companies in yellow. This is the Minep Database and the NICOR database. We record every single year in this country 380,000 people's data. And this just allows us to show you things like this, that if you're in a cardiac ward versus a general ward for patients with heart failure, you are twice as likely to have a mortality in the general ward than you are in the cardiology ward. Your best chance is if you have specialist input under a cardiologist so that your drugs are being optimized before you're discharged. Here are just a number of other infrastructure things. This is the last couple of slides. That in the NHS, while we are brilliant at having access to data, access to patients, reducing variances, we still need to be able to translate new technologies very rapidly. So we have Nhs Digital, which is our unifying body across all hospitals for what software we have, what hardware standards. And now we have NHSX, which will be rolled into another new organization, the strategic arm, being given almost £50 million in grants last year to technologies such as echocardiography, such as urine analysis with your mobile phone, etc., trying to innovate the NHS so that it's more affordable. We have an amazing project called Nhs Digi Trials, where routinely used data is allowed to support research. Let's have a look at Nhs Digi Trials. We already collect data on patients, where they are, what their GP records are, and whether they live and survive. We've actually said, let's continue those routine data, not replicate those in clinical trials. And the first large-scale trial we used that on was the recovery trial, where for the world we found dexamethasone had a true important benefit in patients in ITU with COVID-19. And that was done very rapidly within 4 months of starting the trial, because we were using routine data sets already existing in the NHS to collect data. Clinical trials and registry data are really highly important. I think in the Russian infrastructure, you have such a large confederation and such a large population, you can easily collect data such as the Etna AF, 14,000 patients. You could probably do that in just a few months. We actually had to use 10 countries. We had to use 900 sites to collect this data over a year. 1 year data shows that in the landmark trials, Adoxaban performs just as well in registry data as in randomized control trials for prevention of strokes. So this is a sort of infrastructure. So this is the last slide. I'm really sorry that all of those slides were components of this single brain map, which is to say, this is the evolution of the future of doctors. Doctors not only fix patients, they fix systems. We have to collaborate with scientists, researchers, and industry and patients and data ethicists. And finally, prevention has arrived. So this is the take-home message. Thank you so much for listening and this opportunity to show you what's happening in the London environment for digital and cardiology.
Большое спасибо, профессор Бахай.
Thank you very much, Professor Bachai.
Следующий доклад я вынужден представить сам себя.
I'm introducing myself.
Меня зовут Дмитрий Куропеев, я
My name is
заместитель
Dmitry
генерального
Kuropev. I'm
директора
Deputy
по
Director for
информационным
IT
технологиям
and
и проектному
Project
управлению
Management
Центра
at
Алмазова.
Almazov National Medical Research Center.
И сегодня я бы хотел...
And today I'd like to tell you about a couple of our projects within the framework of Smart Hospital that we have been implementing and realizing in our center. So can you see my slides? Well, first and foremost, when we just began with the concept of Smart Hospital, we wanted to get the terminology right, and we wanted to answer ourselves, based on the global experience, what is the difference between traditional, digital, and smart hospital? So here we have brief explanations of differences between a conventional or traditional hospital. The conventional hospital is when we have a siloed information system, predominantly paper document turnaround and unstructured storage of data contained in those information systems. In this country, as of today, we have a federal project for integrated digital content in healthcare within the framework of National Priority Project Health that presupposes that every medical institution going from conventional to digital way of operation. The government takes it as not just an infrastructural project, but also a very important ideological project, because this is at the core of digital transformation. You cannot carry out digital transformation otherwise, as have been mentioned by the previous speakers. So we need integration of all information systems for a hospital to be digital hospital, integration of regional and federal level, and
решений на базе технологий искусственного пациентов и мониторинга инженерных систем. Я прошу прощения за накладку. Я вынужден прервать. Да. Извините, пожалуйста. Создавать ситуацию.
Уважаемые сотрудники и посетители центра, 16 часов.
Извините еще раз. Применение технологий дистанционного мониторинга и реабилитации и реализация концепции ценностной медицины. И таким образом мы получаем многоуровневую стратегию информатизации здравоохранения, где на базовом уровне находится государственная система здравоохранения, государственная система, единая государственная информационная система здравоохранения, вертикально интегрированные медицинские информационные системы по нозологиям. Это очень интересный проект, который начат в нашей стране 2 года назад, к сожалению.
That has been started in this country 2 years ago. Unfortunately, I don't have time to amplify on that today. And the next level is the regional level, this being registries, electronic health records. And the next level is medical institution and smart hospitals. So this pyramid generates multiple data that asks for predictive analysis, prescriptive analysis, benchmarking, scoring. This analysis should be there to create decision-making support systems based on artificial intelligence and machine learning to create new technologies that would be fed into each of the levels in the pyramid and then tested and generate new data. And so this is a continuous loop. So in order to have it in place locally in our center, we developed a smart hospital project a couple of years ago. It's aimed at business process management. In your conventional hospital, like I said, you more often than not, you have subjective choice, you have manual data collection, and the managerial decisions are made subjectively, from the gut, intuitively, based on insufficient and sometimes controversial data. And we decided to turn all our processes digital. We create digital twins of various clinical and non-clinical units of ours, and thus by acquiring statistics from our medical and non-medical systems, we get an opportunity to carry out experiments. to create simulation models and thus respond to issues and to answer the question of what we can and what we should indeed change in the routine processes or the new processes that we're about to introduce in our center or improve. Just by way of illustrating one of technologies of simulation modeling we use with our colleagues from the cluster, the ITMO University. This is a new type of simulation modeling when the patients and staff members are followed with the special sensors, and thus we get more exact data on patient movement and make heat maps and study the cross-section of patient flows and medical specialist flows and use it in virtual experiments to optimize and sometimes significantly optimize these flows. In this very brief video, you can see a virtual model created. We can make use of almost all resources, human resources or technical resources, to simulate real admission centers where we can constrain or add resources for each process, and thus we get analytical data that are provided to us in real time and that allow us to get answers to multiple questions related to how to optimize our processes. An important part of our smart hospital project is related to speech synthesis and speech recognition. These kind of technologies are already very much in our lives. It's ubiquitous, I would say, even. In smartphones, it's everywhere, and it's hard to overestimate in medicine as well. We should split it into two parts: the technologies that are on the front end interacting with our customers, this being related to automation of our contact centers, and the second part has to do with doctors' technology, the synthesis of transcription and image recognition in forming protocols of studies by voice. We have been working on automating our contact center, and we managed to substantially increase the quality of managing our inbound and outbound calls, not just to confirm an appointment, but we're also experimenting getting patient histories, family histories, and filling in and the quality of data using subjective questionnaires. So robots call and they collect this data. In terms of simplifying the job for the doctors, it's also very important because obviously doctors spend too much time to introduce medical and non-medical data into information systems. So we offer our doctors a service to fill in their protocols, US protocols, and many other types of surveys and tests, in order to simplify the job for doctors. Jointly with Joyce Labs and the developers of medical system, we developed a couple of ways to support decision making in filling in the standard templates that allows for more high quality and more structured approach to introduce the clinical diagnosis, to prescribe medicine, and to control for data integrity and data consistency. These kind of approaches allowed us to gain up to 90% standardization of introducing medical data. Obviously, this tells on its purity, its quality, and it allows us to get highest possible result in creating this kind of documents. So they are more full, more consistent, more correct. We're also experimenting not just with decision-making support systems, we also embarked on predictive analysis system using cluster analysis and machine learning jointly with Technical University ITMO. We now predict acute coronary syndrome fatality. So we picked out of 30,000 patients, we picked a group of patients and we predicted the fatality and mortality, and we can predict their ways. So we formed we can see three main clusters, three pathways for our patients. And now we are ready for the next stage, the prescriptive analysis, what needs to be done in order to send the patient along the pathway that envisages more positive outcome for that patient. DMSS decision-making support system is pretty complicated, as illustrated by this very busy diagram. Even if we have algorithm-based decision-making support systems, they are pretty complicated, and you cannot go forward unless you have close contact between IT specialists and doctors that complement each other, that exchange data. We already have very interesting instances where IT specialists gets very much in depth into medical issues, and some doctors, quite on the contrary, are very deep into machine learning algorithms and artificial intelligence. Yet another project that we find very important is safety by way of in-hospital telemetry. Our concept is that out of 1,500 of our patients that are daily inside the wards in our clinical wards in our hospital, each of those 1,500 patients should get the remote monitoring device. If we're talking about ITUs, these are going to be bedside. In wards, it also could be bedside, but for most, those will be wearables. As of today, we're experimenting with a vast number of both local and foreign manufacturers of those wearables that are integratable into our information system, so as to compile all the necessary information depending on the risk score of that patient. So jointly with our medical system data, this allows us to create unique systems for predictive and sometimes prescriptive analytics, online monitoring, and prevention of adverse events for patients while they are in our hospital. And one of the components of the system is the creation of a tele ICU. When we monitor patients in our ICUs, and we have 230 beds in our ICUs with various specialties. Our ICUs are very broad, from neonatal ones to cardio and cardiosurgical, neurosurgical patients. So this huge volume of information obviously asks for in-depth analysis, so that we don't miss anything that is really important in tactics of approaching this or that patient, and to prevent developing of emergencies. So it's been a while, thanks to our colleagues from Schwabe, thanks to Polytechnical University, and in cooperation with some foreign companies, including Philips, we create these centers that are going to be one of the drivers in our smart hospital concept. The analytics that we get in our center that we're currently developing is based on the principle of internal benchmarking. It's well-known technology that consists of 5 stages, this being planning, pattern search, monitoring, analysis, and adaptation. So it's a continuous flow that allows to identify best practices, that allows to follow the quality of introducing new systems and adapt best practices in the areas where this could be applied. So we make use of our medical information system. We also create our own system for e-benchmarking based on the modern BI systems, business intelligence systems, that is. Our center is one of the national medical research center, so we curate 4 federal districts of 40 regions in cardiology and 19 for cardiosurgery, and we offer our colleagues in the regions a very important system of benchmarking, external benchmarking. By this way, we help them to look whether or not they are in the line with the National Priority Project on combating cardiovascular diseases as part of National Priority Project House. So in each region, the healthcare officials and doctors can look at target indicators within this project, as well as other projects and as well as other indicators that are important to understand how well cardiology works in this particular region. This allows to identify best practices, implement those best practices, deploy them, and understand their round status, where they are in the Gartner quadrants diagram. We work closely with manufacturers of hospital equipment, including Rostec and Schwabach Holding and others. And here I'm demonstrating to you a small video that will show you how we managed to go from visualizations to reality, real practice. So this is smart word that is now being saturated with, enriched with new technologies. So this is a smart ward where any kind of surveys can be done at the bedside, and all the data that you get, then they can be subsequently used in organizing doctor-doctor consultations like this. So you can attach any diagnostic equipment to it, and you can organize a online counseling so as to resolve a particular difficult case in terms of diagnostics and care. We also hope that jointly with our colleagues will launch a pilot operation of several types of wearables that we definitely need for our project inside our hospital, and also for remote monitoring of the patients, the ambulatory patients that are being rehabilitated, that participate, say, in our clinical trials, or that would wish to be monitored by our center or any other center. And in conclusion, I'd like to point out that the strategic task of implementing components of Smart Hospital are freeing up the time of medical personnel from routine operation for personal interaction with patients, reduction on potentially preventable complications and all kinds of interventions, informatization of the full cycle of healthcare, including rehabilitation and follow-up, integration with smart city, smart home, and also safety inside hospital, safe data transfer, safe intervention. With this, I thank you for your attention. And now we move on in our agenda, and I'm happy to give the floor for the next presentation to Professor Dr. Zahil Yousaf, consultant cardiologist and senior lecturer honorary of University Hospital of Wales and Cardiff University, lead clinician on heart failure and cardiomyopathies in South Wales. And he's going to talk to us about a digital future for heart failure, lessons from COVID. The floor is yours.
Thank you very much. It's a real pleasure to be associated with this meeting today, and I really thank you for inviting me to talk. So I'm going to give a short talk on my personal journey through digitalization of the management of heart failure patients under my care at the University Hospital of Wales. It's a real grassroots presentation today. So I'm going to talk to you about the processes that we've been through and how we've tried to go from a face-to-face seeing patients culture to moving on to digitalized patient consultations. So who would have known that, you know, in the last 18 months, the world would have completely changed through this COVID pandemic that we're all suffering from. This is data from the Johns Hopkins website from this morning, and as of this morning, there were about 127 million people affected or infected, or reportedly to be suffering from COVID-19 infection, and just over 2.5 million people have died from this infection. And you know, COVID, just to remind us that COVID itself is a very small virus. We've known about it since the 1960s. It's a single-stranded RNA virus, less than 1,000th the size of a human hair, and it presents predominantly with respiratory distress. And as we've heard, it causes ventilatory demands, causes severe respiratory disease, and it is highly contagious. And what's worrying is that the newer variants of COVID are even more contagious than the original variants of COVID. And this means that it's an airborne spread of this virus. And that has meant that throughout the world, we've had to limit human-to-human interactions and contacts. So we've had very, very strict social isolation protocols throughout the world, and very aggressive lockdown measures that we're seeing throughout the world as well. So against this background, this is where I work. I work in Wales. So Wales is one of the four components of the United Kingdom: England, Scotland, Northern Ireland, and Wales. The capital of Wales is Cardiff. We are a devolved nation, so healthcare is actually devolved to Wales, and we're part of the National Health Service. But there are some differences in the way we are funded in Wales. So we are one of the few NHS providers that don't work by a fee for service model. We get given a budget at the beginning of the year, and at the end of the year, we have to use that budget up. There's no more extra money. The more work we do, the more demands are on that budget. And we have to provide healthcare services for about 3.5 million people in Wales. And what's very interesting about Wales is that we have our own intranet site. So I don't know if this is how true this is, but I was told that the NHS Wales intranet is the second most secure intranet service in the world, second to this the Singapore military, I'm told. This means that all the information in Wales, all the digital information in Wales stays in Wales, and we can freely share it amongst ourselves in Wales. But it's actually very difficult for me to share some clinical information, images, blood results, clinic letters with people, my neighbors, for example. So it'd be very difficult for me to send images or clinical details to someone like Martin in London, or Amit in London as well. So we're quite isolated from a digital perspective. but that in itself brings in some advantages as well. So I have the privilege of being the lead clinician or the director of heart function services for Southeast Wales. So we look after a population of 1.4 million patients. And the service that we've got is broadly divided into two types. In the green boxes here, we've got the services that we deliver to our local population, about 500,000 people, the population around Cardiff. And we do all the routine stuff that any heart failure service would do. We look after patients admitted to hospital with acute heart failure. We have community-based clinics. We run multidisciplinary optimization clinics. We have a very active palliative care service where we look after the end-of-life needs of some of our patients. We have cardiac rehabilitation and day hospital services as well. And then we have some specialist clinics for some new novel therapies. So that's for our local population, but we're also a tertiary referral center, and we get referrals for patients with complex inherited cardiac conditions, the cardiomyopathies, for example. We have a very active cardiac device implant service. We look after the patients with chemotherapy and the late effects of cardiac toxicity, effects of late effects of cardiotoxic medications. We look after the neuromuscular patients, and I'll come back to that later on. So these are the muscular dystrophy patients, the patients with neurological conditions who put them at risk of cardiac conditions in the long term. We don't have a heart transplant center in Wales, and we refer our patients mainly to England for LVAD implants and transplants, but we look after the patients who've received their LVADs and transplants here as well. And then the other tertiary services that we provide are looking after patients with pulmonary hypertension and sports cardiology. So I've done a lot of consultancy work for the Welsh Football Association and the Football League. We obviously have, a very florid rugby culture in Wales. And so during the COVID pandemic, we had some protocols regarding fitness and return to play. And we were involved in the protocols for that. So the bottom line is that we've got a very, very busy heart failure service. We see at least 100, 150 patients every week. And these are generally elderly patients, multiple comorbidities who've had recurrent hospitalizations. Every time a patient with heart failure is admitted to hospital, they've got a 40 to 50% chance of being readmitted with acute heart failure in the next 12 months. And we've got some special populations under our umbrella as well. The neuromuscular patients are a particularly vulnerable and very high risk group of patients who really we should do everything to keep out of hospital as much as possible. Our heart transplant patients obviously are heavily immunosuppressed, and we need to try to keep them out of hospital as well. So that's our background population and our background workload. In addition to that, though, obviously the world goes on and heart failure goes on, and the prevalence and incidence of heart failure is about 1% per year. So we will be expecting to see more new heart failure patients presenting as the natural disease or the natural condition of heart failure progresses. So we were expecting to see more patients enter the service. And COVID itself has accelerated that new patient referral database because of COVID-related heart failure. A lot of patients in the early stages of the COVID pandemic were hesitant to come into hospital, so a lot of them had their heart attacks at home. They didn't receive the primary PCI. And so now they're presenting with late onset heart failure or post-infarct heart failure. And COVID itself, COVID infection itself, as you know, can cause myocarditis and heart failure in the convalescent period. So that's the substrate, the heart failure substrate that we've been working with. And we wanted to make sure that we tried to keep our patients out of hospital as much as possible, but as safely as possible. And what we didn't want to do is any harm. So we went through a whole series of discussions, and we really accelerated our implementation of digital technologies. So a lot of the things I'm going to talk about, you've already talked about already, but this was our sort of journey into implementing and really turbocharging and accelerating our adoption of these technologies. So we start off with the initial referral of our patients. And as I've mentioned, NHS Wales has a very secular health database, and we have something called the Welsh Clinical Portal, where all the clinical information on the patients is dumped into. So you put in the patient's NHS number or the hospital number, and you get the patient's demographics, the date of birth, their address. But also you click on this tab here and it gives you all the documents, all the clinical letters that have ever been written on that patient. Throughout Wales, if the patient had any blood tests done in any part of Wales, we can see the results on this tab as well. We have a list of the medications that the patient has taken, the prescription sheet. And what's very novel is that we can also tap into the GP records of the patients. So we know exactly what's happening to the patient when they go to the GP, the family physician, how many times the patient is going to the family physician, what other illnesses is the patient suffering from. And then the events tab tells you exactly what hospital contacts the patient has had, how many times they've been to the physiotherapist, for example, how many times they've been to the pharmacist, what's happened there. And then we've got a few tabs here regarding messages to healthcare professionals, what to do next time you see the patient. So I may see a patient today, and I would really like the patient to have some electrolytes checked in 2 weeks' time, because I know that they're seeing the neurologist in 2 weeks' time. So I can actually put a little alert there for the neurologist to say, can you please check some blood tests or check a blood pressure when he comes to see you. So when the referral comes into us, and again, we've talked about digitizing the voice translation dictations of referrals. A lot of our referrers quite like the idea of just talking into a dictaphone and actually having that automatically translated to text without it having to go through a secretary to type. And that's gone down very, very well. But we get a referral which is populated with all this information. And then once I get this, and this is actually my homepage, so it actually tells me that I've got about 200 referrals still to prioritize in there. I can go in and look at the referrals, and then I can make a decision. But before I can make a decision, I need access to what tests the patient has had done. So on this tab, we've got access to the chest X-rays and the blood tests. But being a cardiologist, I need access to the cardio-specific investigations that the patient may have had. And our hospital subscribes to the GE system. We use the Muse system here, which works very, very well. So I can then tap into the Muse database, put in the patient information, and I can access the ECG of the patient, the Holter tapes, the blood pressure monitors, the event monitors, any exercise tests that the patient may have had anywhere in Wales, which is then posted onto this Muse system. Very, very useful for decision making. And then we can go into the Dicom Viewer. So again, there are many Dicom viewers out on the market. This is just a generic GE Dicom viewer that we've got, but all echo images, MRI images, all the cath lab information, the pressure wire studies, the IVA studies can all be dumped onto this Dicom viewer, and I can see them from my office desk or even from my home if I remotely log on. So I can use this information that's in the referral database, accessing the GP's records. I can look at the specialist investigations that the patient has had, and then I can decide what we're going to do with this patient. Am I going to manage this patient remotely? If I'm going to manage him remotely, then do I need to arrange any further additional tests? And then when the tests become available, I can then decide how I'm going to follow up that patient, whether I can discharge him back to the GP and reassure the patient, or whether I need to see the patient myself because I need to discuss the implications of the investigations. And in general, we've audited this practice, and about 40% of our patients fall into this group where we can manage them remotely. So I probably don't need to see them at all. Then there's the other group of patients who, I'm sorry, I'm just trying to hide some of these meeting controls. Okay. Then in another group of patients, about a third of the patients, I can actually make the diagnosis quite confidently on the information that I've got already, and I can initiate a care pathway for that patient. So from the basis of the information I've got, the GP may say that the patient is complaining of chest pain. I can look through the GP's records and I can see that the patient has had hypertension for many years. He's a smoker, he's diabetic. That patient probably needs his coronary arteries looking at. I could potentially list him directly for a coronary angiogram and a PCI, or I might arrange a CT coronary angiogram. So about a third of the patients, you can directly make a diagnosis on them. About a fifth of the patients, there's something that alerts us on the referral letters, and we actually need a virtual consultation with that patient. And that can be done using one of the many platforms that are available, either Teams or Zoom platforms. We can actually see the patient by video consultation. And finally, about a third of the patients, there is something there that we actually do need to see the patient face to face. And so about a tenth of the patients who are referred to me now, I'm actually arranging to see them face to face. So about 90% of patients actually are being kept out of actually coming to hospital for their initial consultation. And then we've got the next group of patients. The next phase of the management of the patients is, okay, when they've been put into their care pathways, I might write a letter and say, right, this patient has got left ventricular systolic dysfunction. There's no role for further intervention, and we just need to optimize this patient's medications. And so I work with a whole team of nurses who are absolutely expert in optimizing patients' medications. And what the heart failure nurses do, they have a cohort of their own patients, and we have multidisciplinary team meetings twice a week. And we decide, and we try and triage the patients in terms of, does this patient need to be seen in person, or can we actually manage to see the patient virtually through a video consultation? Obviously, the main purpose of these optimization clinics is to give the patients confidence to stay at home, and to try and keep them out of hospital. So, sometimes we actually bring the patient in and see them face to face because we want to keep them out of hospital. But just by seeing them for a 10-20 minute consultation, we can actually achieve that goal. And we're finding that about 80% of these patients, we can actually see them virtually. For the optimization, and we've already discussed the wearable technologies that a lot of these patients are having, but we're really adopting and we're tapping into those resources now. So we're actually getting the pulses and the blood pressures and the temperatures and the weights of these patients sent to us remotely, and we're able to decide what medications we're going to titrate up or down. We've also engaged in exercise rehabilitation. We're strong believers of exercise rehabilitation in heart failure. So we actually have online exercise rehabilitation for these patients. And finally, I think Dimitri mentioned the value-based healthcare. So a lot of our patients are filling in online patient-related outcome measures, and that's going directly into the web, into the cloud. So they're sent reminders to fill out questionnaires, and that data is going into the International Healthcare Consortium of Outcome Measures database, and hopefully that the global data will guide what interventions are valuable to patients rather than being evidence-based or quality of life-based. So the optimization clinics seem to be running very, very well, and most of our patients are staying out of hospital for that. Martin knows a lot about the remote follow-up and management of these patients, so I'm not going to go into too much detail, but we implant a lot of devices in our patients, and until recently, most of our patients were actually followed up in person in clinics. But as COVID started, we've actually made a policy decision now to follow up all of our device patients remotely. And so this information is now available in the cloud. And every day, instead of seeing the patients, our physiologists are now looking at screens and remotely monitoring these patients. Most of our follow-up, in fact, all of our follow-up for devices is concentrates on the device function itself, the battery life and the mechanics of the device. We haven't yet dipped into the heart failure variables and the heart failure management of the patient. And we can discuss that later. We've got Martin's presence here, and I'm sure he's got some views on that. But we haven't actually dipped into that yet. And then finally, as I mentioned, we've got a number of high-risk patients that we look after as well. So this is a patient with Duchenne muscular dystrophy. He's got a neuromuscular disease. He's ventilated, non-invasively ventilated at home. He's doing very, very well, but he's the last person that we'd want to have in hospital. But these patients are at risk of developing cardiomyopathies over the long term. And, the protocols and the guidelines suggest that they need to be seen every year to have a cardiac assessment. So we're actually posting out monitors for these patients. So in the post, they receive instructions on how to apply a Holter monitor, 24-hour blood pressure monitors. We've even got patches that we post out to these patients, and then they return the information back to us, and we can remotely monitor their cardiac condition. Echoing these patients, as you can imagine, is very, very difficult, but we are following them up with biomarkers. And as Amit mentioned earlier in his talk, biomarkers may be the way forward in these sort of cases, but it's early days to make any conclusive remarks on that. So this is my last slide, and this has been a year-long sort of learning curve for me. There have been lots and lots of lessons that we've learned. There have been many things that have worked well. I think the most important thing is that the NHS in England has adapted fantastically to the rigors and the challenges thrown at us by COVID. Our staff and patients of digital medicine, and none of our patients have actually rejected or declined the offer of interacting with our digital interventions. One thing that's happened is COVID has really allowed us to rapidly implement our digital technologies. A lot of the things that I've talked about were already in the system, and they were in the background, and we talked about it for a long time, and every time we tried to implement them, we were coming across barriers. This can't be done, we don't have the funding for this, but actually COVID gave us an absolutely fantastic excuse to implement all of these technologies almost overnight. It's the first time in 20 years in my hospital where I've actually been able to go to my managers and say, right, we need to do this because it's going to keep the patients out of hospital. We're going to save ventilator beds. And the boxes were ticked. So COVID has actually been very, very good to allow the rapid implementation of a lot of technologies. The one thing I'm very proud of is, we've moved towards a completely paperless service now. So I go to clinic now, I see patients, and I don't have any notes with me at all. It's all done digitally. We've audited the satisfaction and the experience of our patients, and over 90% of patients strongly support this digitalization of their healthcare, and they would recommend it to other patients. The environmental benefits have been absolutely mega. For the first time ever, I can actually come into a hospital and park my car in a car space. The car park is completely empty because none of the benefits, the lack of air pollution is going to be massive. You can see the trees and the flowers all blossoming around the hospital at the moment. So that's a massive, massive benefit. And patients have commented that actually, they are saving money. They're not having to come to hospital, take a day off work, which doesn't really matter, matter in a COVID environment. But they're not having to pay for taxis to come into hospital. They're not having to pay very high fees for parking their car. And Amit talked about the heart failure national audit that we do. So we do supply data to that. And our own internal audit has shown that there's been no increase in heart failure admissions to our hospital this year. It'll be interesting to see what the national heart failure audit data shows. But what we have seen is that there has been an increase in inpatient heart failure mortality, both on cardiology wards and non-cardiology wards. And I suspect that's because the sickest patients are actually coming into hospital with their heart failure and sadly dying in hospital with heart failure. So that's something that we probably just need to keep an eye on. And then we've had, lots and lots of challenges as well. And it hasn't all been good news. The IT hardware and software, it's all very expensive. And, our computers are all very, very old. We're still upgrading to Windows 10 operating systems throughout the hospital. Sometimes it takes 20 minutes just to boot up a computer. Our IT support teams are heavily stretched at the moment. They're being pulled in all sorts of directions, and so that's something that we really need to invest in. I think Dimitri mentioned the multi-provider interfaces. When you have lots and lots of digital information coming in, it is absolutely vital and critical for us to be able to interface with these IT systems easily. User licenses are still a problem. So the providers only give you 100 licenses, for example. So if we've got 101 people wanting to use that particular package, you have to wait for someone to log off before you can actually go in. My personal problem is passwords. Every single package that you use has a different password, and the password has to be changed every 3 months. And I just can't keep keep reminding myself of these passwords. Sometimes you have, 15 different packages that you're working on, and each different package has a different password. We've already talked about the issues about data governance and security, and that really is a big problem. One of the challenges that we've come across is with a lot of digitization, a lot of people tapping into the same information. We need to keep very accurate documentation of what we've done with the patients, so that everyone is aware of what's going on with the patient, and we need to be very clear about our management plans with these patients. So, it's been an interesting journey for us, and I'm really interested to see what the long-term outcomes of this are going to be, because this has been a sort of almost like a pilot project for us that we've gone through. And so in the years to come, I'm sure we will see some positive outcomes from implementing these digital technologies. But the final thing I will say is that we have lost the human contact. So, I do find it quite difficult sometimes when I haven't been able to listen to a patient's chest or to actually interact with the patient. And, I can only sum this up by what my last patient actually said to me when he was listening about this. And he actually said to me, "It's all very interesting and very impressive stuff that you're doing, but I would like to see you in person and shake your hand one day." And that human contact is very, very important for our patients. So I'll leave you with that thought. And I really hope that Google Translate hasn't let me down, and that word on the screen says questions and nothing else. Thank you very much.
Thank you. Google translated it right, although our Russian language is a challenge for artificial intelligence. And now on to our last but not least, our next presenter at our webinar. I'm happy to give the floor to Professor Jacqueline Maxon, a Senior Project Manager at EMRAD East Midlands Imaging Network, was in her presentation of EMRAD Review. The floor is yours, Jacqueline.
Lovely, thank you very much. I shall just share my screen, so bear with me. Okay, can you see the screen?
Not yet, no. At this point we can see you.
You can't see me? Okay, let me, let's try again. Technology, just one moment.
Now we can see it, yeah.
Lovely, thank you. So good afternoon, everyone. I'm Jacqueline Maxon. I'm Senior Project Manager with EMRAD, which is the East Midlands Radiology Imaging Network, one of the 32 that are coming to fruition now in the UK. So thank you to everybody that's spoken so far. I mean, it's very, very interesting as a layperson. I'm neither academic or clinical, so it's been quite an interesting forum. And we've actually heard quite a lot of the content that I'm also going to go over on my slide deck today. So what is East Midlands Radiology Imaging Network? At the moment in the UK, then, a lot of the trusts work independently. 370 trusts up and down the UK, and it's a lot of work. So over the course of the next year, as part of the long-term plan, we are coming together into imaging networks. However, EMRAD 7 years ago actually took the first step into this as an imaging network. So we are based across the East Midlands, so right in the middle of the UK, and collectively we have 7 trusts ranging from Lincolnshire up in the north east, sorry, my screen's come up, down to Northampton and Kettering, across to Chesterfield, and right in the middle, Nottinghamshire. So came together originally to actually procure a PAC system, a new imaging system radiology. So we had the mandate, came together, selected GE as our provider. It took about 2 years to actually come together and get that system. Now you're probably thinking, what's this got to do with cardiology? But when we come to the end, I think you'll see how we can transfer over what we've learned over the last few years into any other system and across actually the NHS in terms of technical and digitalisation. So we came together, bought a new system, and then really the hardware started. So the governance of actually pulling people together, and it doesn't matter whether it's a radiology system or a new electronic prescribing system, whatever, the governance around it, as we've all heard, is extremely difficult. So how do you get everybody to agree about what data you should share, where, who should you share it with, who actually owns the data, who owns the intellectual properties of that data? So quite a complex landscape to actually navigate your way through. What is the return of investment? So for EMRAD itself, over the lifetime of the project that we've put in with the procurement, we will actually save £30 million. So that's quite vast, and that's by coming together to buy that one system. So again, as we move into cardiology and any other systems going forward, that's just indicative of savings that we made. But it's not just the financial return of investment that's on there. As we heard, you know, from a clinician, what is in it for you? What is in the work? You know, the pathways it do. Is it easy to use? Is it easy to implement? Does it actually talk to the other system? So again, quite a lot to consider. The agreements that you need to go through again with your staff, with your suppliers, to make sure that the systems actually work. Something that's come out now within the UK is around a digital technology assessment. And if it's something that we had a few years ago, I think we'd all be in a better place. So it's ensuring that those 5 areas that we've talked about in terms of interoperability, data sharing, data governance, ease of use, and so forth are actually considered. And when we're actually working with SMEs, small medium enterprises, they're not always aware of actually how to implement into the NHS. So a lot of the SMEs, although they will have exciting technology, sometimes actually fall beside the wayside before we get it to implemented. So ensuring then that your stakeholders as you go along this journey are actually, and again, through to clinician, to the nurse, everyone is actually involved, because if you don't take everybody along with you, you may have purchased a fantastic system, whether it's artificial intelligence we'll come on to, or something to take your bloods, but if the person that's going to use it doesn't feel involved from the beginning, then actually you get quite a lot of fallout and the system just falls by the way. So ensuring then, what is the strategic vision that you have? So with EMRAD, although we came together initially to procure a PAC system, the strategic vision now is what other areas can we move into that we can collectively procure and collectively implement, and then get the collective benefits out of it. So as I said, there's a lot of governance and a lot of cultural shift around this area. already heard from us, you don't really need to see me, only 10%. So that must have been quite a cultural shift, you know, because I think as a patient, when you are unwell, your natural desire is to go and physically see somebody. You know, by sitting in front of that GP or by a consultant, you feel that you've been seen, you've been heard. So it's not just a cultural shift for our clinical colleagues, it's a cultural shift, I think, for public. And I think, as we've said, that with COVID over the last year, that has happened to a degree. A lot more people are, particularly younger generation, you know, we'll log on to a phone, we'll have something that we can wear, so that it has started. But equally, I think the older population, again, we've talked about how many of them now have a smartphone. They'll be quite happy to have that that contact, to not go off to a GP if I can send it across on my phone or some other method, and I can get on with my garden. So cultural shift is really important for both, but then the governance. So just because we can collect data, should we collect the data? And if we collect it, what should we do with it? So in MRAD, we cover a population of over 6.5 million. We have a lot of data, and as somebody said earlier on, without the data, it's just anecdotal. But we have the data, but now what do we do with it? So that's something that we're starting to look at going forward in terms of our strategic vision. How do we now use that data to actually change healthcare, change for the population? What gaps do we have where? What do we actually need to develop as we go forward? I'm sorry, my screen come on. Okay, so the strategy itself, then, say we came together with the PACS procurement. We have over the last 2 years actually ventured into artificial intelligence. Now, each of the trusts in their individual contracts with GE may be exploring various elements of artificial intelligence and machine learning, but predominantly within 2 of our trusts, which is Nottingham University Hospitals and United Lincolnshire Hospitals, we've been looking at breast screening. So working with an SME, how do you use AI for breast screening? It's evident actually that the tools work. They identify, they have the same as good as human reader. But then how do you navigate around the complexity of implementation? So again, as you know, within the UK, we have a lot of national bodies, but how do you get that into the screening programs? How do you replace the human reader? So although the technology is there, sometimes again, the governance and the output, and as we heard earlier on, if a human goes, doesn't read something, doesn't pick up, you're liable. But in the case of when we implement AI, who is still liable? So breast screening, although we've been in the journey for 2 years, we haven't as of today implemented it. There's a lot within the screening programs over the next couple of years where we're looking at prospective trials now to put some of this in. I think over the next year, 18 months, it will go faster. As we've said, one of the advantages, if you can call it that, as COVID, is that actually technology in some areas we have moved quicker. So I'm hoping to see that happen myself, that within the next couple of years we can actually implement some of the AI into the screening programs and use it. Another area that we're starting to look at now within MRAD is around operational AI. So again, to a degree, it's already there. So, we use Alexa at home for operational AI. Can you put the TV on and so forth? But we should also be looking at operational AI in terms of patient appointments. Again, as we've said, do you need to have that follow-up? Can you combine appointments so we don't have to come twice? Where should that patient actually go to a nearer hospital? As long as all of those elements again are covered in terms of ethics and that nobody's at disadvantage, then I think operational AI in the NHS and in healthcare is actually going to improve efficiencies. One of the other areas that we've started to look at is in MS case within the knee. So arthritis, big problem, and again, we've all been sitting at home quite a lot, so we've put on a lot of weight. I'm sure that arthritis is going to be another large problem as we move forward. But again, can we use AI to help support this. Now, absolutely, AI can come along and say, okay, Mrs. Moxon, you've got a degree of arthritis showing, but can we use it to triage me onto the right pathway? That will be the next advantage. So again, combining the AI clinical into the operational. Can I get onto the right pathway, whether that is for exercise and physiotherapy as opposed to surgery? Because again, saving the patient going around the loop within the healthcare system will save a lot of time. Lung is another area that we've been looking at quite a lot, and I know that again there's been a lot within the COVID, but how do you use AI within routine healthcare screening? Again, it's back to the AI will come in and predominantly it might look for a particular problem, but when it's not looking for a problem and spot something else, again, how do you get that into the workflow? And with all of these AIs that we're looking at, how do you then incorporate it into the report? So again, back to, I think one of the speakers earlier on talked about structured reporting. So again, that would save a lot of time if the reports actually pop up and promote you and prompt you to narrate into, again, using your digital technologies. But that's just a few of the areas that we're starting to look at within the East Midlands. Now, I think it's really noticeable that within AI, last year, when we went to the RSNA conference, I think there was over 143 AI companies within that hall. And do some research earlier there towards the end of the last year, half of those are no longer still in place, again, because we haven't been able to move quick enough within healthcare, and it's how to work within the NHS system. How do you get it procured? How do you get it implemented? So I think somebody said earlier on, there's a lot of hype around AI, and I think there is, but I think again over the next year we will start to unpick the AI that can actually help us and improve the pathways for the patients. Now, moving on to cardiology. So as an imaging network, again, it's all about how do we collaborate, how do we share the journey, what to be put in. So one of our trusts has started to look at cardiology within the GE environment, and again, that's something that we would start to roll out hopefully over the next couple of years. So again, it's all about the collaboration. But really coming at it from a different view, from a project implementation, and also then as a patient, how do you put these systems in? Because as we've all had, everyone's busy in their day jobs, everyone needs to actually be seeing the patients, and behind the screens you need the small teams who can come along and work behind the scenes effortlessly and make that difference to patient care. So evolving around a very complex healthcare system, as we've already heard, that there's a lot of governance, a lot of ethics to get through, a lot of research to be undertaken. So it could take a minimum of 2 years to get some of these artificial intelligence in over the next few years. But I think strong communication and process channels. I've been in the NHS for just over 20 years, putting in various projects, and what I've noticed, if you can engage with the academics and the clinical staff from the beginning, bring them along with the journey, if you feel involved, you're more likely to then actually implement and use the product. But what other opportunities do we actually have to collaborate now as we go forward? As somebody said earlier on, budgets are extremely tight. We only have a finite amount of money to spend on our patient population. How do you use that to the best advantage? Every person and every team that you talk to will tell you that they are a priority, and they are. But actually, we've still only got one pot of money, and we have to spread it about. So we sometimes have to say, okay, we can't spend it in that particular system because it's so old, it won't actually talk to one of the others. So you can't bring that data together. So again, it's very challenging. I wouldn't like to be an IT director making some of those decisions sometimes. So what have we learned in EMRAD over the last 7 years? It's very much about collaboration and building trust through transparency. Is getting NHS trust to talk to each other, learning. There's definitely in the digital world, what I've noticed over the last year, there's been a lot more conferences with Teams, Zoom, any of the other platforms that we're using. It does allow people to come together, share ideas, work offline, and see about how we can move forward. There is a lot of national funding at the moment that's being made available to, again, bring some of these projects together. So I think, again, over the next 18 months or so, we should hopefully see some significant changes. But I think one last thing, just in terms of collaboration and transparency, it's also about bringing your patients with you. So within the East Midlands, we do work quite closely with our patient senates, and ensuring that whatever you do, always try and have a patient on any of your projects, because then you actually get to see it from their perspective. Because again, if we start to alienate patients through the implementation of technology, then they won't turn up to their appointments. So we do just need to bring them along. I think even more so now, they are keen to be involved. So open it out, get your patients involved where possible, and help that implementation of your digital technology. So that's it for me. Thank you very much.
Thank you very much. Dear colleagues, ladies and gentlemen, so much for the presentation, but we're in for panel discussion. We already have a lot of questions in the pipeline from our audience. So thank you very much for keeping it with the schedule, and let's go on with the discussion. I'd like to pose my first question to Professor Covey. So the question is this, and probably some of the other participants would like to take this question. We're mentioning that COVID-19 became a considerable driver for information technologies and digitization in terms of deployment of information systems. Some issues are now accelerated. For example, in the Russian Federation, some telemedicine-related projects have been finalized, and in certain regions, special tariffs were created for paying for telemedicine, for medical consultations for chronic disease patients, for care with patients after COVID. Prescription and non-prescription medicine was introduced, and it was no longer prohibited to sell medicines, because earlier it was unavailable online, because obviously this allowed us to safeguard our patients. But the question is this: in Europe and in Great Britain, a year has passed since COVID-19. What are the considerable shifts in terms of toppling the regulatory barriers, reimbursement barriers, and utilization of information technologies, both in hospitals and at home? Very, hands-on, very practical, specific examples what has happened, apart from everybody understanding that they cannot go without digital technologies, and healthcare has to be digital in order to keep providing safe and timely healthcare, not just because of the pandemic, but in routine life. So if you could give such examples.
Yeah, so I think it's a global phenomenon. So specific European examples would be France and Germany. Reimbursement now have codes to support remote monitoring, teleconsultation, and that's a big change in those communities. It's also partly been related to physician resistance to do remote consultation when it's reimbursed at a lower level than face-to-face contact, because it affects their income in some countries, not in the UK. In the USA, Medicare, the huge program that covers most retired population, also overnight became very, very much more supportive of remote consultation. So I think it's when you have an emergency that the policymakers understand the need for rapid change, and they do change. What I think now is a more interesting question is how will this land as we come out of the pandemic? Will everybody go back to the old ways of working, or will it be a blended model, and how blended will it be? But my own vision, I think, is that these are all just different tools. Use face-to-face when it's appropriate, and use digital when that's appropriate. These are all just choices that we need to make, policymakers, regulators, clinicians, patients together. So an interesting time for that kind of blended approach.
Thank you. Anybody else? Would you like to give other examples? Yes, please.
Thank you so much, Dimitri. And in the UK, we have seen a massive acceleration of an understanding of data collaboration. So the Nhs Digi Trials project that I've mentioned is to try to harness the power of new innovations being actually put in without having to do the feasibility separately, without having to do the outcomes separately. So we literally we can give the intervention, and we can see the routinely collected data, tell you what's happening to those patients a year down the line, 6 months down the line. So the data is harnessed automatically, the structure is already there. Funding is also being provided. You can see I've put into the chat there the NHSX AI winners for technology innovations for £50 million worth in last year. And you can see that there are 40 different technologies, many of which are being welcomed. Now, there are global digital exemplars, 10 of them, which have gone paperless 2 years ago. And this year has been awarded yet further funding for 6 hospitals to be the absolute innovation leaders in the country. So you can see that those, Coventry, for example, is one of them. Nottingham is also part of that group. So you'll see that within those technologies, if you partner with those hospitals specifically as SMEs, as software companies, etc., then actually the algorithms get really rich. So the possibility has started already. It is welcoming. The NHS is becoming welcoming to the idea of collaboration in certain units to pilot, and then after that, the translation of those software. HeartFlow is an example in cardiology. HeartFlow software for CT coronary angiograms to see if lesions are significant or not. The NHS has actually provided a 1-year technology grant to any hospital using that technology to make sure that they don't have to pay anything. And then after that, the savings from that year will continue to fund future software. Just examples.
Thank you. Thank you very much. Very interesting indeed. And at this point, I'd like to ask my next question to Professor Bahai and Professor Yousaf in terms of progress in using digital and information technologies in heart failure. We all are knowledgeable of multiple studies that have been carried out in Charité Clinic, Team Heart Failure 1 and 2. They had various results. Some of were more controversial, other were more, well, less controversial, let's put it this way. But not that we see continuation of these studies, well, at least in my knowledge, that we have heard of. So what comes next? Do you have enough evidence to make use of digital technologies, including remote monitoring, to have care for patients with heart failure, or we do not yet have enough evidence proving to us that these technologies are there to improve quality of life of our patients and can be used in a broader fashion?
Here, shall I take the first part?
Sure, yeah.
Thank you so much. Dimitri, is a great question. And as you know, earlier, about 10 years ago and 5 years ago, those technologies of remote monitoring were not providing our heart failure patients the sort of interactions that they required to be optimized. And we didn't have the medications to actually truly optimize them. In the last few years, last 5 years since has become available to us this year, since dapagliflozin has been available to us, since NT biomarkers have been really rapidly available. The remote staff monitoring these patients are actually being able to be enabled to prescribe, to enable to optimize these newer technologies. And then what we're doing is trying to prevent these patients having a deterioration of LV function that is chronic, so that they don't require their ICDs. A lot of patients do not want to have implantable cardiac defibrillators if they can avoid it. And so this work in the last year, we've had 7,000 activations through digital pathways of NT-proBNPs, picking up more patients. We've tripled our awareness of diastolic dysfunction patients, of biventricular patients. So the etiology is changing, the profile is changing, the technology prescriptions are changing. So finally, I think remote monitoring, remote prescribing, remote follow-ups are going to show a benefit, but we're in that year where we're doing it. So like as I hear, 90% of our heart function evaluations have been remote. So ask us next year, but you can already see less admissions, less readmissions, and less device requirements. So the drugs have finally arrived when we can optimize fully, even with low blood pressure and the blood. We've even got machine learning algorithms to see which patients will become hyperkalemic. So we can actually use potassium binders for them. Astra Zeneca has got fantastic drugs, as you know, in the heart failure space. So we're very blessed that we can finally translate the innovations to practice using remote technologies.
Great. Yeah, I've got a slightly different slant on that, and Martin knows a lot about this actually. But when we have these implantable devices, we have the ability to collect a lot of information, a lot of data, and different parameters. And my concern is that I don't think we're collecting the right parameters, or we're not putting the parameters or that information together in the right way. So the earlier studies showed quite a lot of noise, and the number of hospital contacts were actually increased rather than reduced. And you needed dedicated personnel to look at the data and then try and work out what to do with the data. And there's always a little bit of hesitancy. If you've got a patient out in the community and the remote monitoring data is showing that this patient is decompensating, the safest thing to do and the easiest thing to do is to bring them to clinic and see them in clinic. And so, we were finding in the early days that actually we were calling the patients up to clinic more frequently than they would normally have been called up, and a lot of these alerts were false alerts, and so we didn't get our algorithms right. But I think the technology is there, the data is there, we understand the pathophysiology of heart failure. We just need to put it all together and get some decent machine learning or some AI algorithms together so that we can actually fine tune the way we clinically assess these patients. I don't know if Martin's got anything to add to that, or whether he agrees with that or not.
Yeah, I've spent 20 years trying to find the evidence to support Amit's statement that it does improve the outcome for patients. And he's absolutely right that actually one size does not fit all. It's not a concept of remote monitoring of all heart failure patients for the whole journey at every time point with one technology. That doesn't work. It's a matching of what you're trying to achieve with the appropriate technology. So for some patients, all you need is blood pressure and some renal function. You can adjust drugs nicely remotely, as to Amit's point. But for others, to think that setting up a huge system to monitor 14 different data flows from every patient with an ICD, that does not translate into better outcome, at least with the algorithms that we have currently. And it creates a lot of extra workload and false reassurance for patients that it really improves the outcome for them. However, COVID was a different paradigm, which it was, if you can't have face-to-face contact, what's better than no contact? And of course, a lot of these systems are better than no contact at all and produce probably similar outcomes. So it depends what question you're asking, what patient, what decisions you're trying to support. And I think I would try and get across the idea that technology is not technology for its own sake. Technology is there to help support better decision-making. And now, of course, course, with the element of trying to keep human contact only when it's appropriate. But a very good question, Dimitri. It's really the nub of all of this about technology. Let's use it when it helps. And that was part of the problem why reimbursement was so slow, because the evidence wasn't there. Now the situation's changed, they're more supportive, but really because of the social issues rather than the technology issues. So at NICE, for example, in the UK, I used to be a board member, they've created an evidence framework saying, what's the evidence requirement for this technology to be adopted? And if it's a very health and lifestyle app, the evidence requirement's not that great. If, on the other hand, it's something that's very a medical device and could be life-changing or life-threatening, you need a lot of evidence. So it's a proportionate approach, I think, is required.
Thank you. Thank you very much for this in-depth questions. And I'd like to, answers to this wonderful questions. And my first question from the audience goes to Professor Covey. Do you have a special department related to assessing the mobile applications developed globally? Are there any constraints, should you have this, any constraints in assessing mobile applications?
Yeah.
And can they come from other countries, not just Europe, but Russia, for example?
Yeah, it's a very good question and one that everybody's struggling with. So, for example, the FDA in the United States has a new digital unit. In Europe, the European Commission has particular interest in this, and its device regulation, which is actually becoming stricter and more difficult for mobile apps. In the UK, we have a kind of hybrid approach to this. But the problem is there are like 300,000 potential healthcare apps in cardiology. How does a physician navigate? How does a patient navigate what's useful, how reliable they are, whether it leads to better outcome or not? So once again, this proportionate response to it, I think, is what we're finding from regulators and reimbursement across the world. If you're only claiming it helps somebody lose weight or do more exercise, you don't really need a huge amount of reassurance about safety of that app. If, on the other hand, that app is to control your insulin pump for type 1 diabetes, absolutely, you require a lot of reassurance that it's actually reliable and safe. And that's where I think the evidence has to match the healthcare need. This is something European Society of Cardiology has identified, and we have a working group at the moment from industry, from cardiology, from patients, looking at what should we do? Should we advise cardiologists which apps to use? How do we grade them? Why should we do it? Why isn't somebody else doing it? All of those issues. So it's a very, very good question. I'd be very interested actually in Russia, if you could tell us how you are approaching this challenge amongst all of these different apps. It'd be really good to know what you guys are doing.
Sure. I'm happy to give you information on that. We have pretty strict regulation. In order for any innovative wearable device or mobile application or any technology using predictive analytics or recommending prescriptive analytics to be present, it has to be registered as a medical device. Say PPG, ECG devices, they have to become medical devices. And no smartwatch or smart wristwatch are not initially that. But if you like, you can go through this procedure and become awarded a status of medical devices. However, no such precedents, neither European nor Asian manufacturers of devices have gone through this process. In Russia, however, we have several manufacturers who have registered the so-called cardio flashcards, and LF core for their smartphones to register ECGs. In my presentation, I also demonstrated what we do jointly with Rostec State Corporation. We are in a very early prototype stage, or in the first clinical testing, clinical trial stage. As far as mobile applications are concerned, and the use of AI for analytics, there are some examples of this systems, both independent ones and modular ones. Modules to be integrated into medical information systems have been registered as medical devices. Currently, the Ministry of Healthcare has simplified this whole procedure, and rather than taking years, it takes, if you are qualified enough, you can handle in 6 months. Our center constantly participates as an expert center in testing and approbation of these applications for decision management support systems. So regulatory environment is there. It's far from being straightforward. It's rather strict, just like everywhere else, and it does hinder the usage of this technology and reimbursement and the broad use of those technologies in clinical practice. However, I'd like to point out that in the last 18 months, the state has turned off the dead point, I would say. Let's move on to the next question from our audience. And our next question, a block of questions really related to rehabilitation. So probably several of the speakers are going to take these questions. I'm going to voice
This is being published now in tele-rehab. Really to go to some sort of leisure center, wear leisure clothes and meet people that you've never met before and do exercise. You know, if you haven't exercised for 30 years, you don't want to do it in front of everybody else for the first time. So I think it's really exciting and a modern tool to help increase rehab. But I'm sure the others on the call also have lots of experience of this too.
Thank you, Martin. Let me jump in and say we're really blessed. We have a national center of audit center of cardiac rehabilitation. We have a national audit of cardiac rehab. We know that have with their heart failure, for example, or a myocardial infarction, or a stent, or a prior stroke. So with this sort of helping people identify with each other, so they become a real nice support group, and then that's monitored by one particular cardiac nurse, etc. That has worked really well. So groups of 10 to 12 people. So it's really that cohesiveness that provides. However, again, people are not always familiar with these technologies. So we know about half of our patients prior to COVID were not able to use these technologies. So the uptake is still quite poor. So we're trying to see if through COVID things have become easier. But there are 6 or 7 different technologies currently in the NHS. And just to give a short answer for the previous question, recently for a technology company, we've been comparing standards that the Russian software companies actually provide for some of their digital health technologies with the American standards for software. and the DCB standards that I put into the chat that we hold in the NHS, the digital technologies to coming in, and also the MHRA classification for apps. And we're finding that the Russian software companies' standards for creating these apps and technologies are way ahead of anything that the NHS requires. So you're really in a great place, Dimitri. In fact, we're actually coming to you quite often to say, how do we build this? How do we do this? So it's a pleasure to collaborate.
Yeah, and I can just add to that as well, actually. I agree. Our patients absolutely love the remote rehabilitation. So for all the reasons that Martin said, you know, you don't like going interesting is that when we look at the patients afterwards, and we've actually been giving these patients home monitors, we've been looking at their accelerometer data, they continue to participate in exercise activities afterwards as well. And that's really important because previous data has shown that, you know, you go on a 6-week cardiac rehabilitation program and then the patients are forgotten. But these patients stay in contact, as Amit said. You know, if you create this sort of bonded network of patients, they will actually continue to participate in these rehab activities. And we've just been awarded a £3 million grant by the HTA in the UK to look at remote exercise rehabilitation in patients with heart failure and preserved ejection fraction. So we're actually recruiting, or we're just about to start recruiting to that trial. So hopefully in the next 2 or 3 years, we'll be able to feed back with some proper, you know, real world data on how these technologies and remote rehabilitation works.
Thank you very much. And our next question has to do with a very important topic. It has to do with
регистры. Более
of diseases. So, what is the situation in the UK? How strict is regulation of registries? Are there any particular association or society-related registries or private registries, and who have, most importantly, has access to those registries, and what are the results of making use of those registries you can tell us about, and what are the plans to make use of those registries further? Who would like to start?
Well, it's interesting to see the Russian Federation approach to it, and everybody on the call, I'm sure, will be able to chip into this. But just very briefly, I think exactly the issues that you've mentioned in the Russian Federation apply in the UK. We're very good at creating registries in the past. In cardiology, we have a registry for everything you can think about. It was very time consuming. A lot of data had to be manually entered, and we did use it. But the modern way of doing it, of course, is trying to use the electronic medical record, that kind of big data approach, to automatically be able to ask any question you like and see what's happening. And there's a new organization, Health Data Research UK, that tries to bring together all the stakeholders from government down to professional organizations and involving the community and the patient community to try and make it a little bit easier to access the data, to get the ethical approval more quickly, to maximize the value of all this effort, minimize the effort of having to enter it. And we could give you endless examples of different ways of doing it, but it's evolving quite quickly and getting a little bit easier and more efficient. But I think all of us on the call have been used to different systems which are evolving.
That's exactly right, as Martin said. And in fact, Nhs Digi Trials is a project of HDR UK, and HDR UK, Kathy Sutlow, has really spearheaded so much change there. In the next year, we will see the utilization access of the data, and we'll be able to prove that we can access data for good. It has been very, very difficult prior to COVID, extremely difficult to get data out, except for certain parties that may be really close to the data. One of the things that people have been worried about is that the prior data collected has a lot of missing information that can make certain centers look not as good as other centers simply because of the missingness of the data. So the data has never been funded well enough to be absolutely clean. So the integrity of data has always been an issue. However, we're starting to see prospectively that we can, with the electronic systems, so we have Cerner, Epic, etc., and we can use EMIS, we can use hospital episode statistics, we can use the Office of National Statistics data, the prescribing data in the country. The NHS is one organization, which is amazing. It's the rarest beast in that sense. And we were able to pull our entire population's data to work out the order of vaccination, the order of shielding. So literally we did this within a matter of a few months. And this is the first time we've ever managed to do this. And we had the powers because of the pandemic to do that. And so that has really unlocked the ability to share data for good. And so we're going to see change quite nicely in the next year or two. So it's a good time to innovate.
Yeah, we submit data to all the national registries from Wales. So we take part in the Cardiac Society and the National Heart Failure Audits and all the national registries. But in addition to that, we've got a very interesting database in Wales called the SAIL database, which is administered by Swansea University. And what that database does is it taps into the Welsh Clinical Portal. So it has got all the medical information on the patients. But in addition to that, it actually taps into a lot of socioeconomic metrics as well. So we can correlate, the patient's income level, for example, with the area that they live in, with the amount of air pollution in that environment as well, what their occupation is, what their father's occupation is. It's a very, very, very powerful database, and there are lots and lots of sort of studies going on through that database. But tapping into the data is very difficult. If I have a project and I wanted to look at something, there are lots and lots of hurdles to tap into that data, and it is also very costly as well. The charges are quite high.
Thank you very much. Well, in the Russian Federation, we do have barriers as well, although our state has announced and keeps announcing the so-called data lakes and the opportunity to access sanitized, depersonified data in these data lakes, potentially for any companies, including private companies, provided they prove that they are informationally secure and their intentions are good. Well, life will show. At this point, we're at the stage of collecting data, structuring data. Obviously, this does predetermine the quality of subsequent operation with this data. And now I'd like to ask Jacqueline, if I may. My question is this. Mr. Schlachter, academician Schlachter, in his presentation, mentioned a novel approach to training machine learn models, federated learning approach to machine learning, where we can resolve issues related to testing computer vision and decision-making support system on data sets without bringing these data sets together, but rather letting various teams to make use of one common data lake, one common set of models that they could test on their local data set and thus get the results of this particular model optimization. So do you use a federated learning approach in MRED, or are you planning to make use of it?
I can give you an update of what we've did, and then I think Amit is going to add to that. So where we've worked with the AI companies up till now, that has been internally within the NHS, within the organisation itself. So we collected the data, extracted that and put that onto a server and had it de-identified, and then allowed the AI company to come in and put their algorithm with against that data. So it is very difficult. Again, as we've talked about, you know, the governance of how we share the data, something that we're looking at the moment, and you've just been talking about your data lake. So with the amount of data that MRAD actually has, we're just about to undertake an assessment to see what state the data is in. As you say, there's going to be a lot of missing fields. So then how do we make use of that? How do we share that? How do we bring suppliers into the NHS, into our environment? How do we work with the supplier to do that? So quite a lot of work to do. And it's very difficult because once the AI company had come in and got the data and they've trained it, they go back and they've got some questions. So how do you bring them back in and make sure that you get the data set available to them? So it's been challenging. I don't think we had the right solution. You know, 2 years on now, we're actually looking at another data extract and making that available via the cloud as well. So I think the environment is going to change, and we definitely haven't got the right answers at the moment. Amit, you going to add to that?
Yeah, I was just going to talk about NHSX and Dominic Krishnan, who's the lead for the AI project within NHSX that's helping. What we tend to do is allow 2 or 3 hospital groups to run first, and then the learnings from each of those individuals get put into the central repository, and then they're pushed out more widely to whoever wants to. So the federated learning models are locally driven, and then the metadata goes up to the larger scale that's accessible to everybody. We're so blessed that we can transfer so much imaging within the NHS N3 environment previously, and now we've got a new environment called the HSCIC environment, which is, and we've all now moved to Teams in April. The entire NHS, 1.3 million people, were accessible to Microsoft Teams. And so now we'll have access to the Azure cloud, etc. So we're already building those infrastructures. Of course, there's a race between Amazon, Google, and Microsoft as to which cloud will get most of the repositories and where the AI tools are the best. So there's a lot of work to be done, and that's why NHSX's strategy has been to try to diversify that with grants.
Absolutely, and I think, you know, so what we've done today on the other AI companies that we're working with, as you say, we've extracted those data sets, and a lot of the hard work has been done, but it was extracted for that particular purpose with that SME. How do we make that data set, particularly if you think about the breast data set, how do we make that available? And absolutely, we've been having conversations with Dom Cushion. Should that move up and go into the trusted research environment similar to COVID? Where do we start collecting these data sets and make them widely available? But a lot of work to be undertaking that.
Thank you very much indeed. And I guess my final question from the audience, it's pretty broad, so it's open for all of you. If all of you are from Great Britain, then it's about Great Britain. What is the interaction between social sphere, healthcare, and education. Any networking between healthcare, education, and social sphere? Any state projects for interaction between these very important spheres and very, very mutually important spheres?
Well, it's called the United Kingdom, but it's actually 4 devolved nations. So I can speak for England, and it's the Department of Health and Social Care. It changed some years ago. So health and social care is supposed to work together. NICE is also the body that is a gateway to reimbursement, and it has a remit in social care, public health, and the NHS. But in practice, social care is very separate from healthcare, and a real problem. And the education sector is quite separate. So I'm not sure what it's like in the Russian Federation, but it probably can't be any worse than we have in the United Kingdom. But I'm speaking for England. Maybe it's a lot better in Wales.
Actually, it's more complicated in Wales because our Minister of Health is responsible for health, social care, and sport. And obviously, sport always gets the big headlines, and so gets a lot of the attention. No, I mean, seriously speaking, I think Wales has traditionally and historically always been a very deprived country, and so a lot of resources are actually invested in trying to balance out the inequalities in healthcare. So a lot of a big amount of our budget actually goes into primary care services, and trying to tackle the inequalities in healthcare. So social side does get quite a lot of funding, and it's always at the we're always arguing that actually the medical side is not getting that much. The education side is totally different, so there is very little interface or interactions between those departments.
Wow, I never expected that you would be so straightforward and I'm glad we're not having representatives of North Ireland and Scotland. I mean it as a joke, obviously. Well, anyway, thank you for being so straightforward and thank you for being so insightful in your interventions. It's time for us to end our today's webinar. If you have any closing remarks, anything that you wish to share before we close today, if you wish.
Just to say, it's a fantastic pleasure to have this interaction with you in the Russian Federation, and we've got a lot to learn from you, and it'd be really good if we could continue the communication. So thank you very much for the invitation.
Yes, thank you. Seconded.
I'd love to say that we should brainstorm more often together, that we should take up the European offer of the digital conferences and have much more interaction. But also we can do that virtually more often, because the quicker we brainstorm, the quicker we get access to the fantastic Russian technologies of machine learning and the algorithmic thinking, absolutely pivotal. And we're blessed that we're working on the ethical side and the data collections are already there. So I think it's a really great time to create prevention through prediction. Thank you.
Thank you. Thank you very much, colleagues, ladies and gentlemen. Thank you to our audience for being with us for almost 2 hours. I'm pretty sure that each of you have found answers to questions that you had initially before coming and joining us. I totally agree with colleagues out there. We're more than happy as a Russian Cardiology Society and as a part of other state and non-state medical bodies. We're more than happy to participate in these kind of events, exchange opinions, exchange expertise and experience. And probably the travel constraints is a good pretext for us to have new forms of interaction in place and organize our work in a very fruitful fashion, despite it all. but we do still hope that soon enough we'll have an opportunity to see each other and shake each other's hands. Indeed, there are things that left our lives and they are still very important, and hopefully they'll be back to us. So at this, thank you very much for participation. Best of luck. Have a very good day and good evening, and sound health to you and your patients. Stay safe. Goodbye.